Hello, and welcome to our weekly Research in Action series brought to you by the Division of Research at Florida Atlantic University. My name is Jeannie Viviani, and I will be today's host and moderator. It is my great pleasure to introduce today's speaker. Before we get started, we want to welcome you to ask questions of our speaker. Using the Q&A feature of the webinar, please type your questions at any time. At the end of the speaker's presentation, they will answer as many as they can. Joseph Bartholomew earned his PhD in social work and a Master of Social Work from Indiana University and his Bachelor of Science in Health Safety Education from Indiana State University. He is a licensed clinical social worker and licensed clinical addiction counselor in Indiana. His academic and research interests include interprofessional education and collaboration, medication-assisted treatment, mental health, SBIRT, which stands for Screening, Brief Intervention and Referral to Treatment, substance use disorders, social stigma, social policy, and research communication. His career experience includes practice in community mental health and substance use treatment settings, program development and oversight, outpatient therapy services, and mental health and substance use education and training for community, corporate, and civic groups. Dr. Bartholomew, welcome, and the floor is yours.
Thank you so much, Jeannie. Again, my name is Dr. Joseph Bartholomew. Please call me Joe, and it's my privilege to be able to present for you today. Again, I'm an assistant professor in the Phyllis and Harvey Sandler School of Social Work within the College of Social Work and Criminal Justice at Florida Atlantic University. And my presentation here today, titled Double Stigma, Addiction and Recovery, focuses on master's level social workers and their attitudes about alcohol use disorder, opioid use disorder, and medication-assisted treatment. You may be curious as to why addiction, substance use disorders, and other addiction-related topics are a part of my research. And that stems from my experience in working in community mental health centers for many years, working with individuals who experience mental illness, substance use disorders, and related issues to their overall health. I also, on a more personal note, did have family members who experienced various addiction-related issues and did have a sibling who died due to an opioid overdose in the past. So with that, I want to go ahead and provide you an overview as to what we're going to be speaking about today. So first of all, I'm going to share a little bit about the background as to the impetus for the study and the importance of it. And followed by that, I'm going to provide you some significant information in regards to my research study, past research that informed my study, and there were gaps within the past research that guided why I chose the route that I chose, the methods that I undertook for my research study, ultimately my findings and implications from those findings. And again, towards the end, I'll be happy to take any questions that you may have. To give you some background information, we know with substance use disorders, or SUDs, that they are a pattern of substance use leading to clinically significant impairment where a person could potentially seek assistance through clinical services to be able to improve upon their life circumstances. And we know with substance use that it can alter a person's brain circuitry, and that can exist for many years or for a long time after any detox that may occur. SUDs can also involve a lot of craving and withdrawal. And because of that craving and withdrawal, there is a very significant amount of high relapse potential, which can ultimately lead to irregular behaviors. We know through the literature that with substance use development and treatment that approximately 1 in 7 people in the United States are projected to develop a substance use disorder in their lifetime. And of those people, approximately 90% of them who are potentially going to develop a substance use disorder, that 90% of the people who have a substance use disorder go untreated. So we know in reverse that approximately 10% are receiving services for their substance use disorder. We also know that substance use disorders are among the nation's top public health problems, and that has certainly continued even within the lens of the COVID-19 pandemic. More specifically on the 2 substance use disorders that I'm focusing on in this research study, heavy alcohol use we know can lead to an alcohol use disorder. And we know through the Centers for Disease Control that heavy alcohol use rates increased during the COVID-19 pandemic. Moving to opioid use disorder, we know historically that the opioid epidemic began in the early 1990s and it continues today. And the illicit opioid and the non-medical use of prescribed opioids can lead a person to develop an opioid use disorder. And again, during the COVID-19 pandemic, the CDC reports that opioid-related deaths have increased during that time. Now, you may be wondering why I'm showing you this map of the United States, and I'm going to show you another one following. And this is what was interested to me. Being a person from the Midwest, I was very interested in alcohol use disorder and opioid use disorder. So with this chart here, you see prevalence of binge drinking. And I was really fascinated in the Midwest, specifically a tri-state area, where between the states there are different rates. So you can see here, and you'll see me providing more descriptives later, that I was really focusing on this tri-state area of Indiana, Kentucky, and Ohio, because you can see in this tri-state area that there are different rates of binge drinking. And furthermore, when we look at opioid-involved overdose death rates, the same occurs in this tri-state area of Indiana, Kentucky, and Ohio. And you'll see that that's where my participants came from in order to conduct this study. Now, I want to provide you some information about stigma, because we do hear a lot about stigma when it relates to people who experience mental illness and or a substance use disorder, that there's a lot of stigmatized attitudes about stigma when it comes to people who experience such conditions. And what we know that many times stigma, social stigma, by the work of Goffman from the early 60s, that social stigma is socially constructed. And what I mean by that is that the constructs form around various sociodemographics, such as race, gender, disease, and illness. And in this case, with the condition of substance use disorders, there is a mark placed, because we know that the mark, which this stigma term originates from ancient Greek culture, it was a marking such as a branding, a tattoo, something that identified a group that was outside of what the in-group thought was different from the rest. So it differentiates the group. And with that, what happens is a dichotomy is formed. We have two groups. We have the in-group, the us group, and then the out group, the them groups. We have two very distinct groups here that have been developed because of the mark that has been placed. With that, the in group is the group that has power, and the out group is the group that has no power at all. And it's the in group that many times determines what is acceptable in larger society. So what is correct, what is acceptable, what is appropriate in ways that we are to act within larger social circles. But these many times often form around morals that have connections to other entities, or other, excuse me, not entities, but other areas such as religion and culture and so on. So they are based on proper ideas on how a person is to behave, or again, how they are to act in larger society. So what we know with addiction, there's many times people believe that addiction is a choice, a lack of will, a character flaw. And this is what gets dichotomized in us and them. So a person can make the choice, they can have a lack of will, or they have a character flaw, but it gets dichotomized. It can't be both. So you're going to fit in one category or another. So you can't kind of just make a little bit of the choice. You can't have just a little bit of will. You can't have just a little bit of a character flaw. You either have made the choice, you either have the will, or you don't have the character flaw. And that's what I mean about it getting dichotomized. And with that, what happens with substance use disorder and the substance use disorder stigma, that is where the mark is placed on the individual because they have a substance use disorder. And with that, what happens with the in-group who has the power, attitudes are formed, perceptions about people who experience substance use disorders. And then that continues into stereotyping, beliefs about that population and what they'll do and how they act and how they behave. And furthermore, what happens then is prejudice develops from that. And with the prejudice, then by extension, discrimination can occur. Now, some of you may have heard of the term medication-assisted treatment, or MAT or MAT, and medication-assisted treatment is an evidence-based practice that combines two types of recovery approaches. It is FDA-approved medications, such as these for alcohol use disorder, and then these three medications for opioid use disorder. Notice that I have buprenorphine highlighted because we're going to come back to that and talk about that in a moment. But again, it's a two-pronged approach because combined with the FDA medications is a psychosocial intervention. Now, the psychosocial intervention is a large term, an umbrella term that a lot of different interventions can occur. And that can occur in the context of individual or group counseling and such things such as acceptance and commitment therapy, cognitive behavioral therapy, or motivational interviewing. It can also come in the form of peer support that's done in SMART recovery or mutual health programs, such as those that are called 12-step facilitation, which is used in AA and NA, Alcoholics Anonymous and Narcotics Anonymous. But it could also be alternative and holistic approaches, such as meditation, mindfulness, and yoga. But what is important to remember is that to meet the fidelity of the model, both must be employed. Again, it's like a two-pronged approach when it comes to medication-assisted treatment. It is not strictly the use of medications. Now, with MAT stigma, we know that the hegemonic approach for SUD recovery has been through an abstinence-based lens that is used through 12-step facilitation. Because in 12-step facilitation, there is no use of substances in recovery. So, as I had highlighted before, it can be a challenge for someone who uses medication-assisted treatment for their treatment and recovery and provide that psychosocial intervention component through a 12-step facilitation program used in AA or NA. With MAT stigma, the mark is placed on the use of that treatment and recovery approach because many times people feel that a person is not going through the right, proper, again, hegemonic approach when it comes to how recovery and treatment should occur, because it can be viewed as you're merely substituting one substance for another, or you're substituting a drug for another drug, or a medication for a drug. So there it gets stigmatized. And thus, by doing that, you're enabling the individual, and then there's ostracized. People can be ostracized for the use of using MAT as a treatment and recovery approach. Another issue, specifically with buprenorphine, that is the generic name, but you might know it better as Suboxone or Suboxone derivatives. Sometimes it can be diverted. And what I mean by that is people who are prescribed Suboxone, buprenorphine, will sometimes sell it, to sell the buprenorphine in order to attain the funds to be able to purchase illicit opioids such as heroin and heroin derivatives. So therefore, practitioners, whether they're prescribers or providers in the psychosocial intervention, will sometimes be hesitant because they feel like there's a chance for them to be complicit in unlawful activities. And furthermore, some people might be hesitant to engage with the SUD population or SUD patients and clients because by doing so, they're already working with a stigmatized population, but therefore, if they are embracing the use of MAT, they are bringing that type of person into the clinic setting, and therefore there might be some ostracizing that's occurring among their colleagues that they practice with. And furthermore, then that person can be marked as that provider. So, kind of connecting back to the title of this presentation, Double Stigma, what's very important to understand about this is there is SUD stigma and medication-assisted treatment stigma, MAT stigma. SUD stigma and MAT stigma are not mutually exclusive. However, they are distinct on where the stigma is placed. With SUD stigma, the stigma is placed on the condition. With MAT stigma, the stigma is placed on the intervention. Thus, we have double stigma. And that double stigma can be placed on the client and the patient because they have the SUD and they are going through recovery and treatment through a MAT lens. But this double stigma can also be placed on the provider, either the prescriber or the practitioner providing the psychosocial intervention. Now, interesting, as we know, people who experience substance use disorders, there's high comorbidity among people who experience SUDs and also having a mental illness. So there's a potential in some cases for people to have what we call triple stigma, medication-assisted treatment stigma to be used for their SUD, but then many times they also experience a mental illness stigma. How is this significant to the field of social work? I am a social worker and have been a social worker for many years, and as such, I'm an assistant professor in helping educate future master's level social workers, as well as sometimes bachelor's level social workers. So what we know in the social work discipline, that social workers provide approximately 70% of the behavioral health provision in the United States. So if we combine our behavioral health providing peers, even with them combined, we still provide more of the behavioral health prevention in the United States. And because the psychosocial intervention is an equally important component of MAT, social workers will provide that. Also, we know in the literature that social workers are very strong in referral and advocacy for psychotropics for mental disorders, such as schizophrenia, bipolar disorder, major depressive disorder. Furthermore, social workers provide a healthcare gatekeeping and triage approach. We look at very holistic approaches and comprehensive approaches when we work with the clients and patients that we serve. Furthermore, through our discipline of social work, we're always looking at social justice issues and therefore looking at fair treatment access that is bound by our social work code of ethics. And finally, it's an important component of our discipline to educate through an interprofessional education and collaborative lens, where we bring our other healthcare-related discipline peers, bringing them to the table and building and maintaining those bridges so we can provide optimal services to the people that we serve. Now, you may wonder, why is it that I focused on MSWs? And that's what I'm going to explain here in this slide and the following. The MSW in the field of social work, it is considered the gold standard in North America, with more than half of all social workers in the United States possessing an advanced or master's level social work degree. It is the minimum qualification in most states for social work practice and licensure, and it is also needed for clinical services such as psychotherapy and behavioral health diagnostics, being able to diagnose mental health and substance use related conditions. So that is why I focused on the MSW population in this study. Again, that is why it's called the terminal degree. You don't need any advanced education beyond that to conduct these services. Now, past research when it comes to MSWs and medication-assisted treatment, the first study for MSWs and medication-assisted treatment came from Bride and colleagues in 2013 out of the University of Georgia. But there were gaps in their research that I noticed, and these are some of the gaps that thus guided my interest in researching this population and their views and such about AUD, OUD, and MAT. In their study, social workers with a high school diploma were included in their participants. So I wanted to look at the MSW, since it's a terminal degree, and their licensure and clinical service ability. The dependent variable in their study focused on medications, not the MAT model, which is crucial. Again, the medications combined with the psychosocial intervention. And finally, their data collection was collected before the Affordable Care Act was signed into law in 2010. We know the Affordable Care Act, which was signed into law under the Obama administration, expanded services for mental health and substance use disorders, but it didn't take full effect until 2014. Underpinning my research study is a theory called critical social theory. And critical social theory, to kind of give you a broad explanation briefly about what CST is, is there are three core components of critical social theory: enlightenment, empowerment, and emancipation. And I'm going to show you how that factors in to MAT and SUD stigma. So through enlightenment, we bring an awareness to the group, and therefore we raise consciousness. So we enlighten. And with enlightenment, we empower by increasing understanding of what is occurring, and we build that knowledge. And through empowerment, we connect to the emancipation, because the goal is to replace oppressive systems with new ones. And in the context of substance use disorder and MAT stigma, what we want to do is identify those social structures that lead to SUD and MAT stigmas. And with the hope, or the goal, is to hopefully reduce the stigma that is attached to SUD and MAT. So for my research study, I really focused on three different questions. And those questions being, what are MSWs' attitudes towards individuals with AUD and OUD and their acceptance of medication-assisted treatment? What factors predict MSWs' attitudes towards individuals with AUD and OUD? And finally, what factors predict MSWs' acceptance of medication-assisted treatment? So with that, I'm going to break that down a little bit more in detail. So with my data collection, as far as the participants, I used an online survey using Qualtrics software. And I distributed my online survey through 3 state chapters of the National Association of Social Workers: Indiana, Kentucky, and Ohio. So I distributed this survey in the late summer of 2021 through the early fall of 2021. And to meet inclusion criteria, participants had to have a master's level social work degree, so they could have one of these accredited master's level social degrees determined by the Council of Social Work Education, CSWE. So an MSW, an MSSW, or an MSSA. And they also had to be able to, or be employed in a healthcare related setting, such as an emergency department, a hospital, a primary care clinic, a situation or employment location that is primarily addiction related, or behavioral, or primarily behavioral and mental health related. And these two, the person could be practiced in either a community-based setting or a private practice setting. My end result, as far as the number of participants in the study, you can see the breakdown. I had 140 master's level social workers participate in the study. And for statistical analysis, the achieved power for the regression analyses were at 91 and 93%. Now, power is a sensitivity test to the likelihood of finding a significant result with all the detecting the effect when everything is involved in the regression model. All the variables are placed in the regression model. Getting to the various variables and measures that were included in this study, the sociodemographic variables that were included in the study were age, gender identity, political ideology that would range from very conservative to very liberal, the number of years working in addiction, and their social work licensure. Participants also completed a validated tool called the Medical Condition Regard Scale. And with the MCRS, it was 11 items, and you can see they were like or related, and they completed it 3 different times in the same survey. Once for AUD, once for OUD, and once for type 2 diabetes. Now you may be wondering, well, why were you gathering information for type 2 diabetes? AUD and OUD are often considered behavioral conditions, but so can type 2 diabetes, and therefore sometimes the use of insulin that is medication assisted to their treatment. Therefore, that was included. And so a higher total score on the medical condition regard scale meant that there was a more positive attitude toward the condition and people who experience it. Next, they also completed a 12-step facilitation belief scale, only 3 items, again, Likert, and this is a belief scale that has been used in previous studies, and again, a higher total score meant a more alignment with 12-step facilitation beliefs, meaning that abstinence is the appropriate approach when it comes to treatment and recovery. Finally, I wanted to measure attitudes when it came to medication-assisted treatment. There isn't such a scale, so I had to create one. And so with that, I developed this from other scales that were similar, which was pre-tested with MSWs and was 10 items, Likert, and a range of 10 to 70. And this scale meant that the higher total score meant a more acceptance of medication-assisted treatment. I'm going to get a little bit more detailed here on the data analysis and how the data analysis was going to answer the 3 research questions. So first of all, we're looking at attitudes towards AUD, OUD, and type 2 diabetes and the acceptance of medication-assisted treatment. So with that, we sum the scores, and then we use what's called a repeated measures ANOVA. And this is going to answer the first research question. And an ANOVA, a repeated measures ANOVA, compares means of across one or more different variables that are based on repeated observations. Followed, the sociodemographic variables and 12-step facilitation beliefs. Those were going to be connected to predictors of AUD and OUD attitudes that we're going to place in a multiple regression model. So we have 6 predictors in the multiple regression model. And multiple regression model is where we're going to look at regression is a statistical technique that we use in order to analyze the relationship between a single dependent variable and multiple independent variables. And this is going to answer our second research question. Now, interestingly, with the first research question, using the medical condition regard scale with a repeated measures ANOVA, what I do then is sum those scores, and what was a response before it, they now become predictors in themselves, and they are added to the regression model to help us determine predictors of MAT acceptance and then ultimately answer our third research question. And these are being ran twice, once for AUD, once for OUD, for questions number 2 and question number 3. So let's get into some statistics here, and I'm going to keep it simple so it's easily understood, hopefully. So research question number 1, what are MSWs' attitudes towards individuals with AUD and OUD and their acceptance of MAT? So when I ran the ANOVA here with the 3 different conditions, AUD, OUD, type 2 diabetes, there was statistical significance between attitudes about what MSWs thought about people who experience alcohol use disorder and what they had in their attitudes about people who experience opioid use disorder. There is statistical significance here, but I want you to notice something here. We have 49 and 50.49, basically a 1.5 difference between this. Although there is statistical significance here, we have to be careful here because it may not be practical. So there's a 1.5 difference. Yes, there's statistical difference there, but again, it may not be practical. It may not be a big deal, so to speak, that there's a 1.5 difference. But there is noted that there is a difference there between MSWs having a slightly elevated positive attitude towards people who experience AUD compared to those who experience OUD. These are the sociodemographic variables, the predictors that were included in the regression model. And you can see the information based on age. You see the mean age was 49.2. You can see the gender identity breakdown, and you can see a significant, there was a significant proportion of individuals who identified as female who participated in the study. And also on political ideology, there was no one who reported to be very conservative, and you can see a significant amount of those who participated either identified as being moderate or to some extent, at some level, liberal, whether it be somewhat liberal or very. The number of years working in addiction the mean was 6.5 years. And then the social work licensure breakdown, you can see a significant portion were LCSWs, or what we call licensed clinical social workers, or an LSW, a licensed social worker. Again, a licensed clinical social worker has the ability to provide diagnostics as well as psychosocial or psychotherapy, different types of forms of psychotherapies. And there was a small portion that had no licensure whatsoever. The 12-step facilitation beliefs, which is going to become a predictor, the mean was 12.69, which was just ever so slight above the midway point of 12. So there was just an ever so above the midpoint number of 12 that there was a little bit of an alignment towards 12-step facilitation beliefs. Another way of saying that is an abstinence-based lens in recovery and treatment. Research question number 2, what factors predict MSWs' attitudes towards individuals with AUD and OUD? So of all those sociodemographic variables that were placed, the 6 of them, including the 12-step facilitation beliefs, sum scores, the only variable that was statistically significant was the number of years working in addiction. All the other variables were not statistically significant. And on a related note, when it came to doing the multiple regression with type 2 diabetes, the only variable that was statistically significant was those who identified female in the gender identity. So what that means is individuals who identified as female had a statistically significant from those different who identified a different gender identity. Research question number 3, what factors predict MSW's acceptance of MAT? We get a little bit more information here. So the variables for both AUD and OUD, the variables in the regression model that were statistically significant were political ideology, years working in addiction, and those attitudes from the AUD sum scores and the OUD sum scores from that medical condition regard scale. Those were the 3 variables that were statistically significant. But one thing I want you to notice here, notice the negative value here for years working in addiction and years working in opioid use disorder. We're going to find some interesting information here when I break it down and summarize it. So what do we know? Here's a summary of findings. First of all, through the medical condition regard scale, MSWs, master's level social workers, have more favorable attitudes towards clients, patients with alcohol use disorder than those who experience opioid use disorder. However, as I said before, there's statistical significance there, but we have to be careful with it because it may not be practical. It may not matter that much. Also, with more years working in addiction, MSW's attitudes towards individuals with AUD and OUD were more positive. So basically, people who worked in the field longer had more favorable attitudes towards those who experienced both of those substance use disorders. Looking at the MAT acceptance, the MAT scale that I constructed, however, was not validated. It has yet to be validated. The mean was 51.61, and a 50 was a cutoff point for being somewhat positive or somewhat in alignment with MAT as an acceptable approach for recovery and treatment. So we're just a little bit above that somewhat positive view. Also, with a more liberal political ideology, MSW's acceptance of MAT increased. In addition, more favorable attitudes towards clients and patients with AUD and OUD, MSW's acceptance of MAT increased. Now, if you remember from the previous slide, I said, notice those 2 negative values. What is very interesting here, we have a paradox. With more years working in addiction, MSW's attitudes towards individuals with AUD and OUD were more positive. However, with more years working in addiction, MSW's acceptance of MAT decreased. It increased here, but it decreased here. What does that mean? Well, there could be reasons for that. It could be that the participants who were completing the survey may work in a facility where MAT is either not used or they don't have access to it. But it could also be that they don't have the knowledge to feel comfortable in engaging in using in incorporating MAT into their scope of practice. So with social workers, they may have just a little bit of knowledge of it, but they may not feel comfortable about it because they have not been educated. They have not been trained. They may not understand the evidence-based practice that it is, and therefore that could have influenced how they responded about it. So with this study, there were limitations, and as any study that's ever conducted, there always is. So again, as I mentioned before, the difference between AUD and OUD was statistically significant, but it may not be practical. The generalizability is always a challenge. It was a convenient sample. They were not randomly selected. The sample was overwhelmingly female and white, which is not uncommon within the social work discipline. That's very common. There could be social desirability, response bias. The MAT scale, the Cronbach's alpha on the MAT scale, although it was very good, because with a Cronbach's alpha score, you typically want to be above 80, and this was at 0.92. Cronbach's alpha is a score that says you're measuring what you want to measure. And even though that was a high score, additional testing is needed because it's not a validated instrument. And finally, effect sizes of the two regression models that were ran for AUD and OUD, the R-squared, the variances that predict that percent of the model were low. So we had 11 through 29. It got better in the second round of regression when we added the AUD and OUD attitude scores from the MCRS, but these are still considered somewhat low. Now, when I collected, implications. So there's a lot of implications when it comes to our discipline of social work. So with practice, we need to continue to advocate for and refer to our medicine prescribing peers, physicians, physician assistants, nurse practitioners for the provision of psychosocial interventions. So we can continue to do that, but we need to incorporate that with being able to advocate and refer for medications as a part of a MAT model. Policy, we need to continue to lead those interprofessional efforts and those collaborative endeavors to improve addiction education and treatment and bring that into our curriculums when it comes to in educating master's level social workers who are about to embark on their career post-degree completion. Continuing education and training, addictions, SUDs, recovery and treatment, specifically on medication-assisted treatment. It is slowly immersing into those curriculums throughout MSW programs in the nation, but it still is lacking and needs to be increased. And of course, awareness and reflection. And this is a big one. I work with a lot of students, and I am constantly telling them that we must reflect on our attitudes, our biases, and our stigma. And even though we're a discipline that we do meet people where they are, and we understand our code of ethics, and we understand social injustice issues, that even within our discipline, we can still have attitudes and biases, and then by extension, possess stigma towards certain populations. And if we can work on these, the ultimate outcome is to improve client and patient health outcomes. When I collected this data, there was a lot of other data that I collected, which I'm still going through and analyzing. Like I mentioned, I was looking at that tri-state area, so I want to look at the differences between the states. Race, ethnicity, recovery status. I asked if the individuals who participated, if they were in recovery themselves, which can have a factor into it. The community setting in which they practice, whether it was an urban, suburban, or rural area. Healthcare related practice settings such as behavioral health, mental health, hospital-based, and so on. I want to put that in another regression model. How many years they've been in MSW, post-degree completion. The percentage of their work week involved with addiction. It's not uncommon for many people who work in this broad umbrella of mental health services and substance use disorders. They may just have a certain percentage of their work week that they only work with individuals who experience SUDs. How does that factor into it? Their self-reported familiarity with addiction, and then of course addiction counseling licensure, which is very different and nuanced from state to state. So I'm conducting further quantitative analysis for that. But I'm also looking at some qualitative research with some participant interviews and looking at some qualitative analyses that I am interested in and have done in the past, such as narrative analysis and grounded theory. Grounded theory meaning that we collect the data and we build the theory, basically ground up from there to determine how that's factoring into all that's being analyzed. So with that, I'm at about 38 minutes, and here's my reference listing. And with that, I want to thank you so much for your attendance. It was a privilege to be able to present for you today, and I'll be happy to field any questions that you may have at this time.
Joe, that was fascinating. Thank you so much.
Thank you.
I actually have some questions for you.
Yeah.
I invite the audience to certainly use your Q&A function of the webinar and ask some questions of Dr. Bartholomew. But let me just start off first by just asking going all the way back to the beginning of your presentation. You used the definition of stigma based on Goffman in 1963 to just frame what stigma is. But I'm curious too, now that you've done this study, do you see opportunity to look at it through the lens of the social transparency that we have with our social media, and whether or not that could have an impact on how you define stigma?
Oh, absolutely. And I love that question, because as we know, social media has become such a big part of people's lives, whether you personally connect with it or not. We see it in the news, and certainly the stigmatizing that occurs through social media posts that are inaccurate adds to layers of stigma, but it can also be used for good, because we can educate people in regards to stigma and what has been occurring. And certainly with the COVID pandemic, but it was certainly occurring well before the COVID-19 pandemic, is the importance of mental health and doing self-care, and the importance of identifying if I'm at hazardous or high-risk substance use. So there's certainly other theorists, philosophers, if you will, who have different viewpoints in regards to how stigma is constructed. But I focused on Goffman. Goffman, for a lot of a different way or a simple way of saying it, is one of the first who really dove into it and identified how stigma works within larger society.
Great. Awesome. I think we had somebody who just wanted to acknowledge what a great presentation was. Matthew Patterson mentioned something in the Q&A.
Thank you, Matthew.
Another question is regarding technology. So through all of your studies, you were looking at certain locations where MSWs would be working in a clinical aspect. And we do know that a lot of clinical practice has moved significantly online to online platforms. Do you see that as being any kind of a removal of stigma now that it might be, for instance, a little bit more private or secure? What would you think about that?
Very much potentially. I haven't researched that myself, and I haven't read any recent literature about that. And I think that that's because it's still being analyzed and developed. I love that question, though, because I think that's interesting, because people do feel potentially more safe, secure, comfortable in order to talk about those things when they aren't in a community-based setting, and they can be in the comfort of their own home to discuss such things. That's a great question.
Great. Got a couple more that came in. Daniela Cracknell asked, what is the most prevalent mental illness associated with SUD?
I don't know specifically which one, but my recollection from my experience that people and it depends on the substance use disorder. So, but I think one of the most prevalent is major depressive disorder, and probably bipolar disorder, because sometimes people tend to self-medicate to deal with or to manage issues related to bipolar disorder, the depressive and the manic system, the manic symptoms. And so I would say those are probably the two leading, but I can't cite specific literature to that extent.
Okay. Joy McClellan asks, have you considered how geography might impact stigma too in South Florida versus other communities based on our demographics?
You know, I love that question. I am a recent
Transplant?
Florida transplant. Thank you. I'm a recent transplant to Southeast Florida. I just relocated here last summer of 2022, and I have learned that there is a high concentration of substance use disorder treatment and recovery facilities here. So that is something that I'm very interested in pursuing here in the near future. So I appreciate that question.
Another question from Matthew Patterson. Did you collect any data on practitioners' personal recovery experience? Did you find that practitioners in recovery from SUD, many of whom practice 12-step, held more biases against MAT and other recovery pathways?
I did collect I had a question in my survey if the participant was in recovery themselves.
Mm-hmm.
And I have that data, but I have not ran that analysis yet to see how that factors into the area, the setting in which they practice, and their attitudes towards AUD and OUD in regards to an abstinence-based approach versus a medication-assisted treatment approach. But that's coming soon, hopefully.
It's a lot of data to go through, of course.
It is, yeah, and it takes a little time. I wish I could do it quickly, but I jokingly say I can do statistics, but I'm not a statistician.
Yes, that's usually what happens, right?
Right.
And then you think you have a small data set, but it's actually like, wow, I have a lot of data.
I have a lot of data there.
Yeah. Another one just came in. Why do you think that there is stigma about MAT among social workers, and why?
Well, again, the abstinence-based approach to treatment and recovery has been the hegemonic approach since the 20s. And that is so ingrained in our society. And therefore, with that, there's no use of substances. And social workers, even though I think that we understand that we are proponents of social justice and proponents of equal access for treatment, those beliefs are still ingrained in our pre-social work education. And even with our wonderful, robust education on addiction, to some extent, depending on the bachelor's and master's level, those beliefs are still a little bit ingrained. And I think that we're very open to other approaches, but I think sometimes enough information is not shared about MAT. So therefore, they feel as strongly as to the benefits from it. Even though we know it to be an evidence-based practice, there's still sometimes beliefs that they are connected to an abstinence-based. And through the abstinence-based lens, through that facilitation, 12-step facilitation scale, there are a lot of underlying religious components to those questions. So it can be connected to a religious undertone with those questions. And so sometimes people connect that to their own beliefs in a religious context.
Interesting. And you didn't collect religion leanings or religious
background? No.
Nope.
No, I did not. But that would be a great one to collect in the future.
That's true. But going along the lines of historically the educational piece, how long, I guess it's a history question for you more than anything else, how long has MAT been used as an intervention for either SUD or OUD?
Well, look at it this way. The model is the combination of medications, FDA approved, with a psychosocial intervention. And that psychosocial intervention is very broad. You can think about it as just a support system in combination with. So let's look at tobacco use disorder. Using a medication such as Chantix or nasal spray patches, nicotine patches, nasal spray, lozenges, and so on, and attending any type of support group for smoking cessation, that meets the model for medication-assisted treatment. The medications for alcohol use disorder have been in existence for quite some time, but they have been underutilized often because of some of the issues that might arise by their use. But really, MAT really got pushed to the forefront when the opioid epidemic began in the early 90s because of there's like a three-pronged approach, not a three-pronged approach, let me retract that, kind of three factors that led to the opioid epidemic. And that was using pain as a sixth vital sign, the misinformation that was being provided by pharmacies about the non-addictive nature of opioid medications, and then being the cancer pain at the time, being told that that medications for pain relief due to cancer was being underutilized. So it was happening in the very, very late 80s and certainly in the early 90s when that began.
Wow. I have one more question for you, and it pertains to other types of addiction disorders. So obviously, when it concerns SUD or OUD, those are a chemical, in addition to maybe cognitive, but it's a chemical-based addiction. Mm-hmm. And I'm wondering, just based on how things are moving in the discipline or in the environment, are other addiction disorders such as gambling, or it could be social media, or it could be food, other types of addiction disorders, is there any kind of voice that this study will have informed any other types of addiction disorders?
The diagnostical statistical manual that we use right now for diagnosing such substance use related disorders, there are researchers right now seeing if this MAT model can be used for other substance-based disorders. Gambling disorder is the only action or behavioral based disorder in the DSM. And although we hear about social media social media addiction or internet addiction or even sex addiction, those aren't per se in the DSM. So I know that researchers are continually looking, but I can't cite any data specifically on those more behavioral related substance or disorders such as gambling disorder.
Interesting. Last call. Anybody else for more Q&A? Well, Joe, it's been a pleasure having you on here, and thank you for a very informative webinar. And we look forward to the next one when you get through a lot of your stats.
Thank you so much, Jeannie, and Janelle. Thank you so much for your time, and thank you for this privilege to present for everybody.
You're very welcome. Thank you so much. Take care.
You too.
Bye-bye.
Bye-bye.